Nasser and I were lucky enough to spend the last week together on service. And so, yeah, that was a great presentation that we just heard and very relevant to a lot of the work that I do. But I am going to be talking about a totally different project, kind of a side project of mine in a different capacity. So thank you so much for the opportunity to present this work. Let's just go. So I have nothing interesting to disclose except this project was funded by our Seattle Children's Center for Quality and Patient Safety. And I do have to disclose that I'm originally Canadian, so it's always amazing to talk to fellow Canadians. And given our current climate, I have one question for you all. Working on my kids' Canadian citizenship paperwork right now, because who knows? Um, anyway, and I think this is particularly relevant given the topic of talking about inclusive demographic surveys and thinking more about inclusivity and equity. So I'm going to just briefly kind of run through this project and how we designed and executed it. And then hopefully we'll have some time for questions. So I might go a little fast because I would love to hear people's thoughts. So just starting with why we did this project. So I direct our patient-reported outcomes program, which is really basically our survey program. It's really a QI research hybrid program. So we administer surveys without IRB approval. And it's just like in the context of improving the quality of care at Seattle Children's, we ask about health-related quality of life, experiences with care, symptomatology, and then we also have a research data banking study. So if families consent for research, that's when we'll present a research consent, and it basically just allows us to bank their survey responses with identifiers so that researchers in the future can then use these data and link it to other data from the EMR or whatever other data sets that they have access to. So it's kind of a cool hybrid program and gives us a little more flexibility. We focus on outcomes, measure development, and help teams do that for either QI research teams or researchers. And then we also do PRO administration. And I will say we don't just do patient-reported outcomes, we also do feasibility and acceptability surveys for QI interventions. And part of this program, it's been going since 2011, is that with any of the surveys we are doing for any project, we're routinely collecting a demographic survey with it. So in 2020, as you may know, America kind of hit a racial reckoning with three or more, I would say, high-profile tragic deaths. And so that got a lot of people thinking, and our team thinking, how can we rethink the work that we're doing and make it more inclusive, focus on equity, and prioritize this moving forward. And so we decided to redesign our program, and that included hiring program staff who were representative of our patients and families, prioritizing projects with an equity focus, prioritization of underrepresented voices by kind of disassociating IRB from the work that we were doing in quality improvement, and then really thinking about how we were presenting materials to family and being more inclusive with that. And with that, we realized our demographic survey was not very inclusive and respectful and great because we had been using it for 10 years and didn't change it. So we undertook a project to redesign our demographic survey. So this wasn't like a big, like, hey, grant funded research project. This was just us trying to like make things a little better and ended up being a pretty cool project. So we decided to publish it. So I have a lot of expertise in survey design, and so we decided to use the seven-step design framework and hit on many of these. And so we started with a literature review, and again, this was just based on like the common demographic categories we had in our demographic survey, but we did look in the literature to see what literature was available about how to design these questions. Have people done this before? And we found a few articles for like particular categories, but not one that did like a whole demographic survey. And so we ultimately included 21 sources, either from the literature, 8 of our own institutional survey items that we were using, and one expert opinion about language for care item. And came up with a list of questions that we could present to experts. So some limitations of this is we didn't actually ask families, is this a problem and should we do a survey to address it? And which categories to focus on, but we kind of focused on the ones that are typically in your like table one in a research study. So then we came up with several options for each of these categories, and then we presented them to experts at our mostly at our institution. And these were either content experts, so researchers who focus on gender identity or language access, other health equity researchers, or administrators at our organization. And given those COVID, I think that's a pretty decent response rate, but we got 8 experts out of the total of 15 invited to respond. And really, what we were asking them is, are there items that we missed from our literature review because we didn't undertake a systematic review? I would even say we narrowly did a scoping review. So we really wanted to know, like, are we missing some like major things and questions that we should be offering as options? Then we asked them to rank the options that we provided and then also provide us open-ended feedback on any of the items. And some they just like did track changes and sent us a Word document back. And some we actually set up verbal interviews and kind of took field notes of those interviews. And then ultimately we took the rankings, the feedback, and made decisions as a team to retain, remove, or revise items for the next step. And so some examples of this for gender identity and sex, and sorry, I'm just trying to keep track of time, is that we had 3 options and experts, for example, ranked the first option really low because they just felt like it wasn't inclusive enough. And so we retained 2. And then for race and ethnicity, and we'll talk a little bit more about this, but we had this item where ethnicity was split up from race. And that was kind of the traditional way of asking about race and ethnicity. And the experts really didn't like this one. So we actually removed it because it tended to be very confusing for families, especially Latino families who are trying to understand which race to put down when they identify as Latino. So, anyway, so we ended up not retaining this item. And then we ultimately took 17 items from our literature review and ended up with 13 items for our next step. And our next step was pre-testing, and that included basically going to the end user and asking families what they thought. And so we did a family review of these items from August 2022 to 2023. And we use purposive sampling. So we primarily talk to families who are on the hospital wards just because they're an easy to access population. And as we were going through, we were keeping track of our sample demographics to figure out what categories are we maybe missing some diversity. And we noticed with language and gender, we were missing some diversity like partway through. And so we specifically reached out to some primary care clinics that had more language diversity, and then also our gender clinic to see if we could partner with them and test this further to get a better demographically diverse sample. As we were doing this process, it was very iterative, and so we were making decisions about removing, retaining items as the interviews were going on. We met probably every other month to kind of discuss where we were and look at the data. So we were asking in these interviews about understandability of the question, getting feedback on parents and even patients, understanding and kind of just the way the questions were framed, and then also asking them to rank items so that we could get some quantitative data. And then with our analysis, sorry, I'm just going to minimize this. We looked again at our sample demographics to make sure we were getting a pretty diverse sample. We looked at notes and rankings and then met and really used consensus-based decisions to make decisions about retaining, removing, or revising items. All right, so we presented several options, and I'll just go through a few. This is really busy, but it kind of gives you a sense of how we kind of looked at the quantitative data and then combined items needed. So this is an example of our language items. And what we ultimately found with this one was that it was kind of split. We gave them two options, but they had two items each. And so some people just didn't like half of the option. And so, for example, we realized we were asking what language they receive medical care in when we really wanted to know what their preference was, for what language to use. And then we noticed just some caveats of survey questions where like the question we were asking didn't actually match the response options. So like for language for care, one of the more common questions that's been in the literature is how well do you speak English? And so we used the response options from that, but changed the question and realized it didn't really match. So we fixed that. And families really said that it was important to both get what they primarily speak at home and also what they prefer to use for medical care. We also learned that there are specific dialects that would be important to capture. And then again, changing the response options to match the question and really asking about comfort versus like ability in terms of like how well do you speak English versus how comfortable. It was less stigmatizing to ask how comfortable. And then another example is for socioeconomic status. We asked them their preferences about whether to specifically ask about income, which a lot of people don't do. And we did for several years, but didn't know how to ask this well, and respectfully. And then versus just looking up, zip code data or census tract data and trying to like get an estimate. And families really felt like we should be asking directly about household income. They did not like option two. And then when we asked about yearly versus monthly, we found that more families with, or sorry, families with lower levels of education preferred monthly. So we went with that option versus yearly just to be more inclusive. So like every little kind of word we were also like making decisions about. And so after the family review, we ended up with 9 items. And then this is our inclusive demographic survey. So it's fairly parsimonious. I think one of the kind of areas of feedback we've been getting is like for race and ethnicity, it's a lot to like present all of these options at once. And so we do kind of do like for our red cap, we do provide the major categories first, and they can list all that apply of the major categories, the ones in blue, and then it'll go to another question where they can like select additional categories for each of the major categories they chose. And then language for care, I think we just need to like figure out if they answer yes to, or like a language other than English for home, but not for medical care, how do you then code that? And so I think we still have some work to do to figure that out. And then the elephant in the room was that while we were doing this whole project, the OMB, our Office of Management and Budget, actually did their own project like this for race and ethnicity and published it shortly before we published ours. And so one of the benefits of that was, we didn't want to cause confusion if people were going to use this inclusive demographic survey. So they presented multiple options of how they would consider asking these questions. And figure one was pretty close to ours. So we made sure that all of the subcategories and major categories matched what we were publishing so that people didn't have that discrepancy. And I will say there is a caveat that like all communities are different, all of our patient populations are different. And so people should definitely revise the subcategories based on their population demographics or what makes sense. Same with the language categories. All right, how am I doing on time? Okay. So I'm going to quickly go through this. This is very early data. We're working through it, but we're trying to get a sense of when we look at our electronic health record data, like what is recorded in Epic, versus what are we getting from our inclusive demographic survey data? How closely are those matching, and what percent of misclassification do we have? And so for race and ethnicity, I think the biggest category of um, misclassification is that two item, like separating ethnicity from race. And that is how we currently still ask it at Seattle Children's. And so we are seeing some misclassification there. I think the question is, how does that impact clinical care? How does that impact research? So if somebody marks Latino and white for like those two separate questions, but then it eventually just gets coded as Latino, and that's what they put on the inclusive demographic survey. Is that really a misclassification? So I think we need to do a little bit more investigation there, but it will be nice to get some data on like what is the problem here. And then same with language, the EMR discrete field that kind of just shows up like everywhere about language for care is one field, but then there's a lot of supplemental language comment data. And so when you look at that, the misclassification is less. But you have to kind of dig for those data, Nasser knows. And so like whether dad uses an interpreter, mom doesn't, or whatever, and or if there's a specific dialect. So it actually might have some clinical relevance if the discrete field does not really capture all of the language needs of the family. And so this is, it was a great journey to kind of do this project. It was really a random project that we did, but it was very cool to do. And we hope that people will use this to kind of standardize demographic data collection. And I think in terms of next steps, like I said, number one is really quantifying the magnitude of the problem, doing a little bit more of these analyses to look at epic data versus um, survey data and how what percent of misclassification, and then also doing some observations of like how are these data collected in the emergency room? Like, is like what are we actually providing for families to like answer these questions? And then how are clinicians using these data? How are researchers using these data? How are like our data analysts rolling up these categories to give a researcher race and ethnicity categorizations and like kind of seeing what the magnitude of the problem is there. I think if we are finding that there is a problem and there is misclassification, we can do some quality improvement research to decrease this misclassification through how we're actually asking these questions. And it's something I'm really excited to do. And then really thinking about how do we scale up the standardization, not only at our institution, there's a lot of researchers that are still using very different demographic surveys, but also through collaborations like through our networks like you all have, and similarly working in the US with our Children's Hospital Association. And then maybe we need to wait a new election to get more funding to do this work. Maybe the midterms might be sufficient. We'll see. So just want to thank the people on our research team, our coordinators, the people who wrote the study up with us, and then the funding, Seattle Children's Hospital Center for Quality and Patient Safety. And then, yeah, do we have any time for questions? Sorry,
We
I
do.
talked